Confirmation over the weekend that two new variants of COVID-19 have now been found here. The first is the B.1.6172 variant, which has been found in India. The second is a variant first found in the UK. At the same time, we're expecting our second wave of COVID-19 rollout, the second phase rather, to start next week. In fact, roughly a week from now. At the same time, the US has said it will support a waiver of the intellectual property involved in vaccines. Professor Salim Abdul Karim is the director of CAPRISA. You'll know, of course, he's played an important role as the previous co-chair of the Ministerial Advisory Committee on COVID-19. Professor, good afternoon to you, and thank you very much indeed for your time. I really do appreciate it. So, we now know that the variant that seems to be driving the rise in infections in India is now here. Are you expecting that to have a big impact on the number of cases we can expect to see in South Africa?
Good afternoon, Stephen, and good afternoon to all the viewers. When we look at the B.1.617 variant, the one that was first identified in India, it has a mutation that is the same mutation that we have in the 501YV2 variant that we described in South Africa. And that mutation is in position 484. So this common mutation between the viruses means that there's a reasonable likelihood that we'll have cross-immunity. In other words, those individuals who became infected during South Africa's second wave may have some degree of protection against this new variant. So it's probably not going to have the same degree of impact it would if it was a completely new variant that didn't share mutations with the variant we have circulating already in South Africa.
And then I presume you would agree with Professor Barry Shub. I think he told us here at Newsroom Channel 405 today that he would expect, I think the word he used was probably, that the vaccines that we've procured, Johnson & Johnson and Pfizer, will also work against the 617 variant.
Yeah, I think Professor Shub is spot on. The evidence we have now from viruses that have this 484 mutation, and the B.1.617 variant, the variant that's spreading in India, has a second mutation as well at position 452, which is the same mutation that's present in the variant in California. And in both settings, each of these two mutations, the vaccines, especially the ones that we know well, like Pfizer and Johnson & Johnson, which we are using here, they are both effective against viruses that have each of the two mutations separately. It's not known if they are as effective when the mutations are in combination, but I would not expect it to be any different. So the two vaccines we are rolling out in this country should be equally effective against B.617 from India as they are against the variant that we already have here circulating in South Africa.
Okay, so obviously, I mean, we're all talking about vaccines, we're all trying to procure vaccine doses, we're all trying to ensure that everyone gets vaccinated. And the United States made last week what I think might be a decisive intervention in that the Biden administration supported the idea of a waiver for the intellectual property involved in producing the vaccines at the World Trade Organization. That's going to be very important, but I do have to ask, it's sort of in the Americans' own interest to do that, isn't it? They need to make sure that everyone around the world is vaccinated, even to protect their own people who are being vaccinated quite quickly.
Well, I have to say, Stephen, it was a momentous announcement. When I saw the announcement from Ambassador Tai, proclaiming that they were now supporting this move, it's just, I mean, I would not have expected it. So let's just say it's a really important development and a very positive move. I think when you look at the challenges we're facing, intellectual property is only a very small part of the equation, and much of what goes into making vaccines is actually not in the intellectual property. It's a lot of know-how and tech transfer that will still have to occur, and then we have to have the facilities to make these vaccines. And this decision, and if it is eventually passed, with all countries supporting it, I think will not impact on vaccine availability immediately, but it is really setting the stage for the long-term availability of vaccines, and actually sets the stage for future pandemics, even more importantly. So it is in everybody's interest to deal with a vaccine or a new treatment in the pandemic situation as a global public good. That's a fundamental basis on which we should really treat any successful vaccine or treatment for any pandemic. And this decision lays that foundation. It's not going to help vaccinate the whole world, particularly quickly right now, because countries might be able to use the IP, but to actually make vaccines, it's going to be a lot longer.
It's quite something to do, isn't it? Because the intellectual property behind the vaccines is hugely valuable. I mean, if someone wanted to, they could really make a lot of money. It's really important the world goes the other way in this.
I think what you're touching on is a very fundamental issue. And that is that when it comes to a pandemic situation where there's a crisis and that people have developed some treatment, market forces are problematic because there's such a huge demand and there's no supply for very limited supply. So there's an upsetting of the supply and demand equation that gives immense value to the product and the intellectual property that generates that product. So yes, I mean, somebody who develops a new treatment in a pandemic situation is going to be extremely rich, and they could charge whatever they wanted because the product is in short supply. So in that setting, it makes sense to change the equation and to say market forces should not apply. And the way you do that is to declare it a public health and a public good. And that at a global level will enable it to become available. I mean, we actually dealt with this matter back in 2000 in the AIDS pandemic. When we were dealing with AIDS and new treatments became available, and they were not available to poor countries, this very issue of the intellectual property came up. But there, the problem was solved differently in that the drug companies decided that they will give voluntary licenses. So the IP remained intact. They just gave a voluntary license to generic companies that made the drugs available cheaply in the rest of the world. So they didn't need to undo the IP requirements. But this decision now goes one step further than we did originally back in 2000 for the AIDS pandemic. And so it really has enormous implications for the future.
It's really interesting because, I mean, I presume the waiver is permanent if it's implemented, if it goes through the World Trade Organization. In 10 years' time, companies can't come back, or the U.S. can't come back, or someone else can't be re-elected to the U.S. presidency and come back and say, no, we now want to make money out of it.
Yeah, these things are difficult to tell what's going to happen, but I think it would be very hard to justify that you would consider the situation that this waiver to apply, to only this pandemic and only to these vaccines. Because the same conditions that apply to this situation will apply, when we have our next Ebola outbreak, or we have another, or we have a major flu pandemic. And so, the treatments that we use to treat flu or the vaccines will need to be treated in this way. I would go one step further and say that the IP and all of the know-how and the facilities to manufacture vaccines is one issue. There needs to be a more concerted effort in the distribution of vaccines, because right now, other than the 4 countries where that actually manufacture vaccines, that made vaccines themselves, which is the USA, UK, Russia, and China. Other than those 4 countries, they have unlimited supply available for their own countries. Not unlimited, but they have a more readily available supply, while the rest of the world is really struggling, and they've had to make deals, or they've had to really try and lay their hands on vaccines, because there's only been about 1 billion doses, and we have 8 billion people in the world. So you can imagine that the challenge you got, 8 billion people needing vaccines, and you only have 1 billion available, and that 1 billion is maldistributed, where more than 75% is going to a handful of rich countries.
It's really interesting that, because, I mean, the obvious question is our second phase of our vaccine rollout is supposed to start in a week's time. Do you think it's going to make a big difference? It seems, and maybe it's just where I'm sitting, but I don't sort of feel any sense of excitement building up towards it.
Yeah, I think, in the nature of this pandemic, I have learned that attention span and attention levels vary based on the number of cases. So when we are going into a surge, there'll be a huge outcry. But once the surge is over, people get more settled and less anxious, and they, less concerned about issues. I think for me, it's a very simple equation. And that is that you need to vaccinate a very high proportion of your population in order to really get the viral spread under control. And very few countries can do that at this time, other than probably about 3 or 4 countries. Israel, the UK is getting closer to it, the US closer to it, but really maybe Gibraltar, Bhutan. But other than those handful of countries, no other country has vaccinated enough people to avert a third wave or to make a major impact on viral transmission. So what we're aiming to do right now is to rather look at individual benefit, which is we can't stop the virus from spreading because we haven't vaccinated enough people. And that's across the world, not just South Africa. But what we want to do is we want to reduce the number of people that need hospitals, that get severe disease. And so that's why we want to vaccinate all people. And that's why we need to vaccinate them quickly, because they're the ones who are going to need the hospital care. They're the ones who get most sick. So if we can deal with the elderly and the healthcare workers, just those 2 groups, will have an impact on this epidemic, not in transmission, but certainly in terms of the number of patients who are dying and who have severe disease needing hospital care.
Professor Salim Abdool Karim, really do appreciate the chat. Thanks.